Hello. Welcome to Global Heart Failure session. And today we have two speakers who came from the Atlantic. So we have Marilyn Trasoon. Marilyn, would you introduce yourself?
Hi. Well, good afternoon. I'm Marilyn Trasoon. I'm an advanced practice nurse. I'm a professor at Illinois State University. I am very active in the American Association of Heart Failure Nurses, but also the chairperson of the Heart Failure Patient Foundation located in the U.S. Aside from my professional role, both of my parents experienced heart failure, and I have two brothers that had heart failure. So I've been a caregiver in a variety of roles.
Thank you very much, Marilyn. We have Mark Baines from Canada.
Yeah, thank you so much. Mark Baines. I'm a heart failure survivor of 10 years, a heart transplant recipient of June 6, 2018. I'm the co-founder of the Heart Life Foundation, which is a patient-led organization in Canada that helps to empower, educate, and engage people with heart failure and cardiovascular disease. I didn't know that about you, Marilyn, actually. Yeah, I know the experience, amazing. It's funny that they put the two North Americans in one room together. They didn't want to separate us. They kept us together.
Always be together. Thank you very much, Mark. My name is Baines. I'm from Lithuania, and I am a chair of the Heart Failure Patient Council at Global Heart Hub. I am a heart failure survivor as well. I lived with a left ventricular assisted device for 3 years, and 1 year and a half received a heart transplant. So we're all here to advocate for the patient needs, advocate for the awareness of heart failure, and see where it takes us to develop the optimal care pathway, which is our next speaker, Marilyn. So we'll talk through about how the optimal care pathway looks like and should look like.
So when we talk about the optimal patient pathway, I think it's only reasonable to really talk about prevention first. Because if we can prevent someone from going down this path, by all means, that should be our priority. So when we think about that, really promoting and increasing awareness about a heart healthy lifestyle, starting very young. Coming from the United States, unfortunately, we have an obesity problem. And really looking at how we can go about improving patient outcomes and preventing those issues. So one of the first steps is that of being fully aware of your risk factors. The risk factors that we can modify, which include diet, exercise, good sleep, and rest, but also being aware of those factors that we cannot modify, which are genetics, and being aware of our family history, and really taking time to share that information. In addition, awareness of signs and symptoms. Being a nurse, many times in caring for patients, I would have patients say, oh, I had no idea, I thought I was just getting older, I was more short of breath, I was more fatigued, I wasn't resting well, I was waking up frequently during the night, or, oh gee, I was sleeping with one pillow, then it went to 2 pillows, and now I'm most comfortable sleeping in the recliner. So recognizing and being aware of those signs and symptoms are critically important. Swelling, not only in the legs, but many times people will retain fluid in their abdominal area, which is sometimes difficult to recognize. And they'll think, oh, gee, I ate a little bit more than I should have, but really recognizing those signs and symptoms. So really that's the start, in my opinion, of the optimal pathway of, number one, raising awareness and leading that healthy heart lifestyle, knowing your risk, and understanding and knowing your signs and symptoms. The next step is recognizing that time is critical. When we begin to develop symptoms, I've often been fascinated by the fact that many times people will experience symptoms for a prolonged period of time. And, again, they will associate it with a variety of other factors, but time is really critical. And so being proactive and recognizing, it's far better to ask for medical evaluation and it not be heart failure than to miss a sign or a symptom that should have been recognized. And so you have to act. And so reaching out to that medical provider, whether that's an advanced practice nurse or a primary care physician, but really seeking that assistance and then really articulating what it is you're experiencing. So being very clear and providing as much detail as possible, because that really helps to facilitate understanding and appreciation of what you're experiencing. So when we think about the next steps and that of evaluation, diagnosing heart failure is often delayed, and oftentimes terms are used that, such as a weak heart or difficulty with really narrowing it down. But I listed the citation here, but approximately a year ago, several organizations, the American Heart Association, Heart Failure Society of America, I believe a Canadian Heart Association, European, came together and they developed what they identified as a universal definition of heart failure. And as odd as that may sound, you may think, well, didn't they already have that? But really what they did was they really come together to where that they could everyone could speak the same language with regards to heart failure. And so when you're looking at a diagnosis now, what they recommend is that if you have signs or symptoms of heart failure caused by a structural change, and it is corroborated with either a B-type natriuretic peptide evaluation or objective signs of congestion, that is the definition now of heart failure. Now, a BNP or a B-type natriuretic peptide level, BNP is something that's naturally produced in the heart, and when there is increased pressure and stretch, that level goes up, and so it's a very good marker for heart failure. There are two types of tests. There's what's called the BNP test, or the standard BNP, and then there is NT-proBNP. NT-proBNP has become far more widespread as a blood test, but they both basically measure the same. The NT-proBNP essentially measures the inactive form, and so it has become more prevalent, shall I say, as far as a measurement. But I've listed here the levels, and so this really provides a very clear, objective assessment, very quick. Now in the United States, to obtain a BNP, it takes about 15 minutes. So as you can see, it's something that people can utilize and really provide good evaluation. Now the importance of all of this is because once we have the definition, what we have here is what's called the stages of heart failure. And again, this is universal. There are patients that what we identify are at risk. So those are individuals that are without current or prior symptoms of heart failure, but have those risk factors for heart failure. Pre-heart failure, or stage B, are patients without current or prior symptoms, but have at least one of the following there. As you can see, structural heart disease, abnormal heart function, or an elevated cardiac troponin, or BNP. Stage C is heart failure, and those are individuals with symptoms, and then you have advanced heart failure. And the reason this is important is because there's evidence-based treatment that is based on where a person is at on those stages that can prove beneficial and improve outcomes. In addition, there's classification by ejection fraction, which include a reduced ejection fraction. So this is when that left ventricular, that left lower chamber, when it contracts, it's putting out less than 40%. And the readings are there, but that is another classification. But staging is really kind of the foundation by which we look at initially as far as treatment. So the language has changed, and they've included descriptive terms which include persistent heart failure instead of stable, and heart failure remission rather than recovered. So next steps again, that prompt, accurate diagnosis. Now, when that diagnosis occurs, it's always very, very important to identify what the precipitating factor is. So what brought this person down that path? Is it a narrowing of a coronary artery that potentially could be stented? Was it an abnormal rhythm? Was it a valve problem? So looking at that precipitating factor and seeking to have that addressed. Again, timely evidence-based treatment. Once you have that diagnosis, it is critical to be placed on treatment based upon your diagnosis. And then education. Education is critically important so that individuals can truly understand, because ultimately at the end of the day, you have a very active role in this whole process, in that open dialogue and shared decision making. The more informed an individual is, the more empowered you are to have that conversation, that dialogue, and share in the decision making. And I've listed here, all questions are important, and I think sometimes people are hesitant to ask questions, but each and every question is important. So, again, patients and caregivers need to be engaged and follow the treatment plan. You know, that is, again, as I said, it's a partnership, and so you have to be an active partner, so really be engaged, following the treatment plan, look at and gain access to resources that can help you or the person you're caring for be able to manage heart failure. Prompt, open communication of any changes. Again, that ongoing daily self-assessment is critical, and then regular follow-up. And I put there, and the bottom line is to be an active partner. So ultimately, at the end of the day, the optimal care pathway really involves healthcare providers. They must have the methods in place and ensure that each and every heart failure patient is promptly diagnosed and treated based on the best evidence, and that all patients and caregivers must be aware and act on the symptoms once they occur. So this is a picture not far from my house in the Midwest. Here about 4 weeks ago.
Thank you very much, Norman. So we heard the clinical perspective about how the optimal care pathway should look like in our real world. But then we have Mark Baines with his extensive experience as a patient. And we would like to hear actually what happens in real life on the ground, right, with the patients in different countries. And for this, we have Mark from Canada. And I would like to start with a question, Mark. If you could tell us about your experience of heart failure from the symptom awareness to diagnosis to the point like how you are right now today.
Yeah, of course. How much time do we have? I was a little shocked to see myself so close up. I still look the same maybe when I was 23 years old. When I was diagnosed with heart failure, it wasn't the optimal care pathway that you suggested. It wasn't a prompt diagnosis. It wasn't an accurate diagnosis. I was 23 years old. I just entered the adult stage of my life. I got what I thought was a cold, really. And something I could handle, of course, right? Anyone can handle. And then that developed into what I thought was a flu, so I went to my family doctor, and he said it's probably a flu combined with your childhood asthma coming back. I thought, okay, but what are we to do as adults and children? We listen to our doctor's advice. So I went along my way. From there, over the next 2 weeks, I got progressively worse. So I got to a point where I was walking up my stairs and I was short of breath before I made it to the top. I couldn't sleep laying down. I was sleeping at my kitchen table just to get rest that I needed. And then the chest pain started. And then I went to the hospital for a second opinion. And that's where I had the tests that you mentioned. Not the BNP, but I look at the echo, I look at the ECG and the x-ray. Of course, x-ray I've had before, and some blood work. And the physician came back a few hours later with some concern on his face and said, Mark, you have dilated cardiomyopathy. First I thought, I don't even know what that means. Your heart is failing. That's the first time that I heard the words heart and failure in one sentence. And that was a scary moment from diagnosis. And I lived with heart failure for 10 years, as I mentioned, and I had my ups and downs, as a lot of heart failure patients do. like you've experienced in the past. I live with an ICD, it's not an LVAD, but an ICD. During the ups, things were fantastic. I got back to work, I was able to travel, I was able to get involved in the community. But during the downs, there was times where my family and friends had thought they had lost me. And that's the trajectory of heart failure. It's an unknown unless you have that optimal care. And then in 2018, I'm very grateful to have received my heart transplant. And since then, been doing well and being able to actively participate.
Well, that's a great story, and thank you very much. And we're very grateful to have you here today. Would you tell me what has been the most difficult part in your heart failure journey from patients?
Yeah, no, of course. So being 23, of course, young on the younger side of being diagnosed with heart failure. Like I said, entering the adult stage of my life, I had just traveled for 6 months around the world. I had finished my degree and just gotten into my first career. And my life was essentially put on hold. Where a lot of other folks were moving along with what they were doing in life, their jobs, their careers, whatever it may be. There was always these times where during the down that I alluded to, there was that unknown for me, inability to progress. And you can't necessarily see it. It's an invisible disease. I think we talked about the campaign earlier today about the invisible nation.
Yes.
Heart failure is invisible, so you don't see what that person's going through. So that was challenging.
I totally, being a patient myself, and I can relate to your stories so well, especially knowing that we are similar age. But talking about the changes in life, when you heard your diagnosis, how that impacted your life as a young patient?
Yeah, I mean, it was scary at first. Like I said, I mean, the words heart and failure are not really used in a sentence until you get that diagnosis. And there really was a lot of unknown around it, not just for me. You know, you think about the caregiver and their perspectives and what they have to go through at the time of diagnosis and with their loved one. It's challenging, I think, for all parties. I wasn't sure what the next step was for me in terms of my healthcare, in terms of going back to my career, and what that looked like. You know, really, it wasn't until I met 2 other patients that had gone through the disease, one that had a left ventricular assist device, one that went through a heart transplant, that I really got to understand that there was hope, that heart failure wasn't going to define who I was, that I was able to live a quality of life, albeit a little bit different, that I wanted to live.
And you mentioned about the quality of life. Since the diagnosis, how did you manage to keep yourself being a patient? I know that's a big question for the patient. So living with heart failure, but still trying to keep the best quality life as possible. So how about you?
Yeah, it's a challenging task for sure. And you know, I think about being quite grateful for where I was. I live in Vancouver, BC, a metropolitan area where I have access to 3 major heart centers. My cardiologist was the head of cardiology at the time at St. Paul's. And I had the support around me. So I was able to get the education I needed, get the support I needed, and able to really understand what heart failure meant and what I could do to live the quality of life I wanted. But not everyone has that opportunity or is afforded that opportunity. That's what really helped me move forward.
But like, as from the patient perspective, there are little things that you can do yourself which really impact
Of course.
your numbers of the hospitalization, your progress of the heart failure. So little things like diet, exercise, you know, looking at your mental health. And I know in our work at Global Heart Health, working with patients, the patient organizations will really highlight the importance of the emotional health. And was that the same for you? Like,
you know, not necessarily, not to start. I think really, and you bring up a really good point on mental health, because people always think about heart failure and the physical challenges that people face, but not about the mental and emotional challenges, because it does that, and I think that equally impacts how we progress through our heart failure. For me, it was a lot about learning from others and the experience too. So to an extent, that was there. But in reality, in Canada, we polled our group at Heartline. I think it was 80% of folks were not offered mental health support at the time of diagnosis. But over 95% said that they would have taken it if it was offered. So, you know, for me, of course, there's medical adherence. I would take my medications on time, I would exercise. And, you know, later in my diagnosis that I learned the importance of mental health.
would you say that community or like peer-to-peer conversation is very important?
I think that's one of the most important things. You know, one of the reasons why we started Heartlife was for that peer-to-peer connection. Right? I was fortunate enough to meet my co-founder, Dr. Julian Code, who had gone through this years before me, as well as I said, at diagnosis, my cardiologist introduced me to 2 folks. right? When we met, we've talked ever since, and you were at a different stage than I was. I was a little bit ahead of my heart failure trajectory. I think that peer-to-peer connection is important because you know that there's that community that you're not alone in this, that there's other people out there like that, and that you can live the quality life you want.
And exactly, we can see that through the patient organizations, with the work that we do.
Yeah.
I do in Lithuania, I run the Lithuanian Heart Failure Association, but as well with global heart on the global scale. And we see that this support of having the community just right there is very important, not only for the patients, but all of the caregivers as well, and all the team. So talking about next step, and I would like to ask you if you could tell something that you want people to know about the heart failure.
That's a really good question.
Or understand better.
Yeah, no, of course. I think from a patient perspective, I have advice for people living with the disease is to get the support, ask all the questions, as Marilyn said. Ask the right questions. But to ask the right questions, you want to be empowered to do so. So educate yourself on the disease. Meet other folks with going through this diagnosis. So then you have that courage and ability to go ask those questions. Because you have to be your own advocate in this space. I think that's really important.
Yes, I totally agree. I would like to, I don't know who is here in terms of the audience. Do we have any patients of heart failure? Hi, Stephen. Just from your perspective, what would you say would be your piece of advice for the patients and for other community or people around as well?
Of course, again, reach out to folks that have been through the experience, but it's important to learn about your diagnosis and educate yourself, and then take care of your mental health as well, because I think, again, that's overlooked when you think about heart failure, and it's a huge part of progressing that diagnosis to live the quality of life that you want.
Well, we see definitely quite a difference what Marilyn said in terms of what is the expectation of the optimal care pathway and the real life story, right? When young patient needs to go through diagnosis, in this case, misdiagnosis, as we said, right? And you don't get the diagnosis on time, which is crucial for heart failure patients. You don't start back the treatment on time, and then all the rest is following, right? How we manage our disease and how we manage treatment with heart failure and taking on to the next step. So what we actually did in local Heart Hub, we have launched an international patient and caregiver charter, which actually was adapted from the Canadian Heart Failure Patient Charter. And I'll come back to you, Mark, a little bit later to talk more about how it all started. So the International Patient and Caregiver Charter has been launched this year in June. It was endorsed by 32 global Heart Failure Patient Council affiliates, and it was translated to 16 languages across the Americas, Europe, Middle East, and Australia. So we, as a next step for the charter, we were looking to receive an endorsement from ESC and AHA ACC. And this charter speaks about the patient responsibilities and expectations. But the aim of this charter, the ultimate aim, goal, is to improve the overall quality of life, establish a core set of patient expectations, as well as responsibilities, all upon the policymakers. We have few examples which actually took the document to the next level to engage with the policymakers, to foster the effective collaboration as well with their team, with their multidisciplinary team, with other stakeholders, and to ensure that they are involved in the future research and actually in any development in terms of the treatment guidelines. So the heart failure patient and caregiver charter is not only for the patients or the caregivers, it's as well for the payers, the policymakers, healthcare professionals and healthcare providers, and as well the stakeholders which I already mentioned. And I'm moving back to you, Mark.
Another picture of me.
Another picture.
How did you get these?
Another picture of you, but I really like and admire this slide, not because I'm a patient as well, but we try to when we speak about heart failure, we try to go through the positive connotation because it's very negative, it's shocking. You know, as a patient, you think that your life is over. And I think it says quite a lot about it. It's all about life, right? So Mark, would you tell me what really inspired Heart Life Canada to create the patient engagement charter? Like how the idea came?
Yeah, no, and I think it goes back a lot to optimal care. Like I said, I was fortunate to be in a metropolitan city with all the resources that I needed. But you think about all the people across Canada that don't have that same access that I have, that live in rural areas, that might not have the resources or support or be able to get that education. Just because that does not mean that they should have the different standard of care than I have. And so that really drove it, is to develop that standardized care for all people living with heart failure. It doesn't matter how old you are, where you're from, what you look like, you should have the best care, the right care at the right time, every time.
That's very important. So it says what the patient caregiver charter is. We have some copies back on the table. I will show you the QR codes at the end of the session where you can scan it and have it directly on the phone. Mark, this picture, the award of World Heart Federation, can you please say what the award is for? And
yeah, no, I mean, it was the Effective Voice of the Year. We're very proud to get it. I mean, we don't do it to get awards, but it's great to be recognized on the global stage. And I'll take a moment to say the work that Global Heart Hub has done and you've done to get it into 32 different countries, translated in 17 languages. That's phenomenal since June, to see what we've done in Canada really expand. So not just a Canadian standard of care, but a global standard of care for people living with heart failure. So we can work together then to really impact that policy change, impact that system of care and how heart failure care is delivered.
Absolutely. Would you tell what are the best practices of Heart Life Canada to use actually the charter? Do you have any, like, of course, a great work with it already in Canada? Would you just share that? How impactful it can be? Of course.
Yeah, and we are doing work, and I appreciate the kind words. And I see some of the other organizations like what you're doing in the U.S., what's happening in Australia and Lithuania, and the opportunities that Canada has. In Canada, we've used it on different levels with industry partners, for instance. They use that as part of their training now. So as sales reps or industry partners go through training when they join a company, they look at our charter to say, here's what standards of care for heart failure should look like. For healthcare professionals and health systems, we can help make decisions around the charter principles. Timely access to care, what that looks like, multidisciplinary care, mental health support, input into research. So when I say input into research, Canada just launched the Canadian Institute for Health Research 5-year research grant. We have over 40 patients and caregivers involved. This is a 5-year grant with 127 researchers from across the country. As I mentioned, 40 patients and caregivers. We're following the principles. All the research programs are following the principles of the charter. And then for patients and caregivers, it's really to empower them so they know what they should get as a level of care. So they can take that to their general practitioner, their physician, the heart failure, and say, here's what optimal care can look like from a patient perspective. Because it just wasn't developed by Jillian and I at HeartLife. This is a 2-year project where we work with hundreds of patients and caregivers from across the country to say, what are your priorities and where can we help the most? And so that's really what we've done. And I guess the next question is where we're going with this.
Yes.
And of course, I mean, we just don't want the document to be a document. We want to be able to develop policy change. So we've entered into a partnership with the Institute of Health Economics in Canada, where we're developing a policy document, real actionable policy items around economic analysis that we can take to policymakers and say, if you provide, for instance, accurate and timely diagnosis through NT-proBNP or BP, which, like I said, is a 15-minute test, here's where you can get savings. I think about what Slovenia did on the CVD and their screening. Everyone at 5 years old gets a screening. And I think about that in terms of accurate and timely diagnosis. Make that into a policy change. So this is one of the big things we're working on now, and hope to release this economic document near the end of the year around October.
Congratulations, it's a big work. Actually, we're very inspired by the work that you do, obviously, in Canada, and we try to take it on a global scale. And since the launch of the Heart Failure Patient Caregiver Charter, we actually moved into the next stage of actually localizing the document on a national level and empowering our affiliates at the Heart Failure Patient Council to take this document, to become a champion, as we call, and with applied statistics and data of their own country and proceed for the next steps of where this document can lead and can go and impact the policy, as Mark has mentioned. So since June, we already have had 4 localizations. We had one in Australia, we had in June at the same time, at a similar time in the United States. In the beginning of September, it was launched in Brazil, and September 29, it was launched in Lithuania. So as you can see, these local documents, they were endorsed by the clinical societies. And that is where the goal, because we want to empower the patient organizations to collaborate with their clinical societies, with their multidisciplinary team, to get their policymakers on board. And just to share quickly, because I run Lithuanian Heart Failure organization, and that was my work to bring the Heart Failure Patient Charter in Lithuania. What I personally did is that I invited the different stakeholders, including the Ministry of Health, the Prime Minister Councillor, the payers, and the Cardiac Society to the roundtable discussion, where it actually led to confirming the project which was applied around 1 year ago by the Cardiac Society in Lithuania. And we had agreement and confirmation during this discussion that the BMP, which Ryan mentioned, it will be reimbursed for all the primary care since next year onwards. So that is a very big step in Lithuania, and because of this document, because of this launch and gathering the stakeholders around the table, we actually managed to take the next step and start this collaboration, with everyone, and actually having that impact of reducing hospitalizations and reducing the deaths in Lithuania. And I would like to move to Maryland. Maryland and Heart Failure Patient Foundation in the United States was as well one of the champion organizations which launched an United States Heart Failure Patient Caregiver Charter. And it was led by a Heart Failure Patient Foundation. It was endorsed by Heart Failure Patient Foundation as well as American Association of Heart Failure Nurses and Mended Hearts, and as well launched at the American Association of Heart Failure Nurses annual event in June 2020. So, Marilyn, I have a question for you. So, how the International Patient and Caregiver Charter has inspired your organization, Heart Failure Patient Foundation, to launch the localized version in the United States?
Well, I think that if you look at the US numbers, they are staggering. And so it only makes sense when you look at the charter, the value of it, because it impacts patients, it can serve as a resource for healthcare providers. And so it really pulls everything together. And in talking with a lot of my professional colleagues, the statement is, this is long overdue. So just those words, again, thank you for the template on which it is building. But it was disseminated at this meeting. In the meeting, there was approximately 1,000 in attendance, but it has also been pushed out to all the members of the American Association of Heart Failure Nurses. And with regards to next steps, the goal is to continue to push it out not only to the specialty areas with cardiologists, but a big push towards primary care, because in the United States, similar to Canada, depending on where you live, care varies dramatically. And with that understood, we also recognize that there are limited resources as far as heart failure specialty programs. And so many patients are cared for by primary care, so it only seems reasonable to push that further. As far as additional steps, there's been discussion with regards to the position paper, with regards to the information within the charter, as well as research, which I think is so critically important. That's, I think, again, one of the beauties of this document is it really is very encompassing to include not only the mental health and what I would view as standards of care and expectations of patients, but really moves beyond to look at that of policy and creating change. At the end of the day, that's really the goal, is to create change, to move forward and ensure that each and every patient is cared for by a standard and has equal opportunity to access to that care.
Absolutely. I think, as Mark mentioned, yes, we create the document, but then the real work starts when we actually what we do with this document. So I'm really excited about the next steps of Canadian Happy Patient Charter, of the localized version in the United States, and actually the international charter for the global HARDOC. And we're actually going towards the end of our session. And I have the slides. If you would like to look at the digital version of the document, you can actually use your phone camera and it will direct you on the link. There are 2 languages. There are some printed copies as well back on the table or at the Global HARDOC booth in the main online hall. And because we have a few minutes, I would like to ask if there's any questions that anyone would like to ask us. Yes, please.
Yeah, so thank you and congratulations on the patient charter. It's a really good piece of work there. It's 2 questions in one. First of all, when you did the localization, I was wondering if there were any differences between the countries. And secondly, you have 7 expectations from the patients, which I would interpret as call to actions along the care pathway. Which one has your priority, or in which area is there the biggest gap today in terms of standard of care and where we should be?
I would probably, the first question I would give it to Marilyn, right?
I would say that as far as a priority and the gap, I think the biggest gap is timely diagnosis. And I think that's where we really have to work very hard to make sure around the world that everyone has opportunity for a timely diagnosis, because your outcome ultimately hinges on that accurate diagnosis and being treated in a timely manner.
Mark, would you like to ask something?
Yeah, no, of course. I mean, I think that's a great question. I think that's exactly right. When I think about priority, I think about timely access or timely diagnosis, accurate diagnosis, but then once you're diagnosed, timely access to care. The right care, like you said, right care at the right time. And then focus on that mental health. And that's overarching throughout the stage, is to make sure that that's taken care of along with the physical aspects of our care.
And I would just agree on top of that, it was created by the patients, and the patients voiced out that, receiving an early diagnosis is the most important thing. And that's, I think, it comes to the point of expectation number 1. We want to have early, timely diagnosis, early diagnosis. So I just completely agree with Stephen.
I'm just got something to say in a question for Mark, but it's surprising we've not talked about. One is not just timely diagnosis, it's actually naming the diagnosis, because in my case and a lot of other cases, nobody talked about heart failure for the first 6 weeks. You just told me, your heart's tired, whatever. And that's part and parcel, I think, of having correct diagnosis so that the patient can then take on board. It is a shock when you hear heart failure, less so in French in my case. But at least you know where you are and you can find out what you need to know. The second question is, in Canada, have you managed to get actually cardiologists and doctors to refer patients? You talk about networking and peer-to-peer, which you know me, that's my big thing, and patient education, but we don't seem to be getting the help from the professional community sending us patients, because we, as you are, as associations, we are kind of like the source of, we can help people, educate them, and building the chart and say, you have these rights, so this is what you should be expecting.
Yeah, it's a good question. I think that's, and as organizations and countries, what we should all strive for. We've made significant strides in Canada. I think, speaking to global colleagues, our relationship with our physicians and our healthcare professionals is actually quite good. We have Dr. Sean Brani, who's our medical advisor, and as I mentioned, he was the head of cardiology in the province. We're co-principal investigators on grants with researchers and healthcare professionals. We sit on boards with Cardiac Services BC, for instance, which runs the health system for cardiac services in British Columbia, my home province. So we have those relationships, but it's still a small number of folks that get, I guess, recommended to us, right? So there's still a lot of work to do within heart failure clinics, heart function clinics, and with healthcare professionals where we can say, hey, we do exist.
Yeah.
And the peer-to-peer support is important. So please send people our way. And I think that's something that maybe we can work on. She kneel on the back, and maybe that's a campaign that we work on.
And we can see one more question, please.
Since I also had heart failure and EF of less than 25%, I think that was a close call. Where did they decide on let's go for a transplant? That's a pretty big step.
Yeah, no, I think I'm sure we can probably both answer this question. For me, like I said, I had my ups and downs over 10 years. I had an ICD implanted, which is a cardiac defibrillator, which outpatient heart shock if I need it. And it got to a point in 2017 and 2018 where my heart was essentially too damaged to go on. I was having too many adverse events, cardiac arrests. As my spouse put it earlier, she was in the crowd. Thank you for being here. It's the first time she's heard me speak live. After my ablation, where they tried to burn out scar tissue, the surgeon came in and said, how come Mark's not on the transplant list? This is the worst heart I've ever seen. And they put me on the transplant list. And then here we are. Yeah.